recognize where my passion and progress will go. I have a protocol that is called endocrine care with focus on aging stronger, faster, better. I call it living longer, stronger, faster, better. You'll see in the slides a publication from 10 years ago where we wrote the assumption that intentional weight loss is still part of the plan of care for older people as long as you do it correctly. Because if we let it be, there will be a number of people who may gain weight, develop complications, become get some disabilities or complications, and then continue gaining weight. And we need to stop that. On the other hand, if we were to motivate them to do exercise, and perhaps see some results, they might end up having better outcomes. Everybody's aging, so then there's a whole array of connections between our aging parameters that go beyond what would be considered the traditional adult with diabetes. That maybe has to deal with glucose levels and the medications they take. But as we get older, you'll see, I'll comment more about the interaction between the different geriatric domains. I have a vision that I'm bringing here that I implement that is to consider that everybody's getting older, so we have to try to age better. And while we have no means to prevent aging, and we're getting older by the minute at this moment, there should be ways to improve our physical and mental function. And if we know already what are the five killers and what are the pathophysiologic pathways for them, exercise plays a major role. For years, I did a collaboration with exercise with many sites in the US for thousands of veterans. And the person you see down on the picture, it was a 70-year-old veteran that I hired to be my trainer in my team. And he did tremendously. By the time we finished the project, of course, he retired, and I wish him the best, but he certainly became a better person before he started volunteering for us. So then, in terms of aging, we need to consider that if we age with diabetes, is a more complex circumstance where it's not only about either the weight or the diabetes that will create complications, either cardiovascular or metabolic. You know that obesity is associated with some types of cancer, like breast cancer and colon cancer. And there will be, as I will present later on, connections between both obesity and diabetes and dementia. And this dementia risk not only will create greater complications for the person as they get older, but will also impact how we treat their diabetes and how the diabetes treatment may have challenges. Now, in this slide, I also want to highlight that it's not only about what we call medical domain. Uh, Patients have function or physical function that we give for granted in our earlier years. But once you lose function and you recognize that you need assistance, you start having an insight to how difficult it would be for an older person who may have needs in their functional domain, but may or may not have support under their social domain. Family structures are different, and most of my patients that I consider lucky are the ones who have family or friends to help them go through disability. However, you can imagine, and I want you to think of the difference that will happen in people who may have same challenges, same age, but without social support, or without access to medical care. And that could be a very difficult, very different outcome if these people are also enduring with some type of affection in their mental domain. Mental domain meaning, are they depressed? If they have depression, a person with the characteristics I mentioned, even though they may have access to care, they may not go to the physical therapy sessions, or they may not want to leave the home and will not engage. And under those circumstances, cognitive function will worsen. So, as Shamila mentioned earlier, obesity and diabetes are chronic diseases that are increasing, but I wanted to highlight that not only Sri Lanka or in the US, everywhere in the world, our population is getting older. And if you look at the stats at the top, you'll see that for the people older than 65, as of now, we have more than 830 million in the world. In 10 years, it will surpass the billion. And in 20 years, 1.4 billion. And by 2064, almost 2 billion. So the amount of people that this is a population that is growing, as you could see in the arrow, the orange line, and we need to plan for the future. And again, as we're all getting older, our organs are getting older. When I talk with people who have diabetes and they're 85 years old, I get to tell them that their pancreas is also 85 years old, their liver, their heart, their bowels. So then there will be some conditions that are age related, others are age dependent. And I bring this up, this global view, because again, when you think about somebody, an older person with diabetes, it's not just the type, the A1C in this person. So as we get older, they could have osteosarcopenia, the loss of muscle or bone, challenges with nutrition, maybe some either hormonal problems with the loss of testosterone function or thyroid function. So that will complicate the perspective. And that's only my world, the endocrine world. In terms of diabetes and disease risk, people with diabetes have 2 to 4 times greater risk for coronary artery disease, 2 times greater for stroke, and we're talking about dementia and diabetes. Remember that there will be different types of diabetes, including the vascular. And disability in about 8% compare 8% of people without diabetes can have disability, but 16% with diabetes could have disability. And diabetes per se as a disease is the eighth leading cause of death. With regards to obesity, every 5 points in the BMI can increase the risk for heart failure. And there are 2.8 million deaths per year per the World Health Association attributed to obesity itself. And besides, obesity can be associated with colorectal cancer or postmenopausal breast cancer and other types of cancer. As I mentioned before, it's not only about the metabolic parameters. As people have obesity, and this is a sad view, uh, many people can develop functional impairment and disability. And now, if you had to imagine the persons on the photo, they can do what they can do because they still have some preserved function. But to be able to use a scooter, what if you have diabetes and dementia? They may have the functional decline, but because of the mental decline, they might not be able to use that type of mobility device to maintain independence, and therefore their conditions will worsen. This is a participant that we had in my exercise program, and even though he was using a walker, he was able, and at that moment of the picture, he's doing exercise. So the problem with aging with obesity and in diabetes is not only about the decreased quality of life, but also the increased risk for depression, isolation, or dementia, which then get worse if these people have medical functional problems like disability or pain of addiction, and usually more medical problems under the low socioeconomic conditions lead to worse socioeconomic conditions. Just briefly to address heterogeneity in the sense that what I mentioned doesn't happen the same to everyone under the same circumstances. And in this case, for instance, muscle, you could have lean people with a smaller muscle who are very independent. You could also have, I would call, not necessarily lean, but people with normal weight, but with low muscle mass. That's the people with sarcopenia. Or you could also have people with obesity and low muscle mass. That's called sarcopenic obesity, and their outcomes will be different. And in terms of physical function, fitness is the key. So they've done studies where even by people under the same BMI bracket, they'll do different if they are fit compared to the people who have either less fitness level with overweight, or worse if they have less fitness level with obesity. I want to briefly address that nutrition is a major issue as well, and that's across the world in terms of not knowing how to eat, not knowing how to eat correctly. And most people need some protein supplements to get to the protein targets. Otherwise, they end up dealing with loss of muscle mass and frailty. And in my view, I think it's more of a combination of sarcopenic obesity, diabetes, and even for people who may receive pharmacologic treatment for the right indications that might lead to loss of appetite and then loss of muscle mass. Not also have to consider stress and sleep and the social connections. And there's a situation that I'm afraid might be also occurring in developing countries, which is food insecurity. And it's not about not necessarily having absence of food, but it's having lack of access to good quality food. And as people get older and they may move less, and if they gain weight and they have hormonal changes and they lose muscle while gaining weight, the sarcopenic obesity will lead to more inflammation and more risk, including risk for dementia. For the obesity management, this is the slide I mentioned we published about 10 years, no, 11 years ago. And I wanted to just highlight the point that it's possible to get and take out people from the red vicious cycle, and we just need to foster the green cycle where with interventions, and the basic intervention, the best one in my book is exercise, to gain muscle, to condition those muscles. It might be possible to see some improvements in condition and perhaps an impact in longevity, which is my current research. So if we talk about these risk factors, I'm bringing up to you with these few minutes of introduction to geriatrics to the concept of chronic diseases increasing the risk for a life-threatening, really life-limiting condition that is dementia, for which, at least at this moment, I think I'm correct to say we have no cure. There has been some progress over the past few years and better understanding of the pathophysiology and mechanisms of treatment that could perhaps change the trajectory of dementia in the future. But I don't think we can say yet that there's a true solution for this. Besides, it's a complex problem. So what I told you, and we discussed for 10 minutes, the aging of the world, of the population in the world, the increasing in obesity and cardiometabolic risks like diabetes, and that these factors have already well-established connections with dementia later in life, is certainly the topic of today to address how do we deal with these older people who may already have post-diabetes and dementia. So just in a nutshell, I want to highlight there are different types of dementia. So while I hope there will be a growth in the training and formation of geriatricians, not every dementia is Alzheimer. It's indeed the most common one, but there is also vascular dementia for which we talk about the stroke risk that exists in people with obesity and diabetes, separate to what will be the age-related tau protein-mediated, maybe Alzheimer's disease. There are also other types of dementia that happen in younger population, like the frontotemporal, or other dementias that are associated with different pathophysiologic mechanisms, like the ones of Lewy body with Parkinsonism. Certainly less common, but there are multiple other different types of dementia. But for today's talk, given that the prevalence is much higher, we're going to think the most about the traditional age-related dementia from the syndrome of Alzheimer or the syndrome of vascular dementia or the mixed picture, which again, in many people can coexist not only because they are getting older, but also because they have diseases like diabetes and obesity that will predispose them to have strokes. So I think it's been many years since it has been described. This is from 2009, now 15 years, a connection between uncontrolled diabetes and the risk for Alzheimer's disease. And different papers have indicated that people with diabetes may have more dementia than people without diabetes. And when we talk about the different, again, the slide on the left, the view in general for an older person, this person is not just the A1C for the diabetes or the weight on the scale for the obesity or whatever cognitive testing they may have. Keep in mind, we're still talking about a human being who may still have some decline in their independence in terms of mobility, some variability in terms of their nutrition access, or could be malnutrition. They could still have falls and the risk for fractures, and they could have also infections and one of the separate leading types of potential death. They could have complications from the treatment. Hypoglycemia, low sugar, could be also another factor that is not could be associated with worsening cognitive function, but also a complication in somebody who may have decreased functional state. And for a second, picture your 40-year-old patient with diabetes that you maybe don't even think twice. I mean, you worry if they're going to take the medications the way you tell them to do, but you don't think at that moment if they will remember or they will have issues with cognition or dexterity or the mental ability to handle the prescription. That will change when you're dealing with an 80-year-old with diabetes, obesity, dementia. So, and this is a very important journal cells, and they're already describing the connection between the metabolic implications of increased weight and diabetes and the metabolic changes that happen through these pathways. It's insulin resistance that in people with obesity is not happening in a month or a year. It's through years that can then create changes. And through those changes, we are exposing the body to different factors that will end up coalescing together. We have, as we discussed, the obesity. We talk about physical inactivity or sedentarism or challenges with diet, people with diabetes, developing diabetes. And then, as they have these metabolic factors, metabolic syndrome, as it was described, could involve also the high blood pressure and dyslipidemias, where in this case, people with obesity and metabolic syndrome will have high triglycerides and the low good protector HDL cholesterol. In addition to all this, as obesity increases, there will be liver disease that now has been relabeled as MASLD. It's no longer NAFLD. And then there might be now the impact, and we didn't bring it before, but now it comes up. What will be the genetics background of a person and how now everything else we're discussing here, which will be epigenetics, will increase or change the risk for developing further disease as they get older. And notwithstanding the gut microbiome, for which I'm sure you have heard so many things about their role in health in general for human beings. So this is a very complex circle of circumstances that eventually will develop as risk factors for dementia. Certainly, this is a more complex slide going through what may be the different pathophysiologic pathways in which the circumstances we describe now, the insulin resistance or the obesity or the diabetes, may end up leading through cell apoptosis or neurotoxicity and neuronal damage. And then also it affects the ability of the body to heal itself, and then through the excess generation of free radicals may end up leading to not only metabolic changes at the, liver level or fat level or muscle level, but the brain level. And in that sense, this certainly creates an interesting scenario for us to understand how cognitive changes may start even sooner, we may consider. Let me then remind everybody for a second that the at least for the CDC in the US, things might change in other places, but the leading causes of death may change for people 65 and older versus the people 85 and older. On the left, for most of us, if we worry about heart disease or cancer, that's true. But if we make it above 85, heart disease is still prevalent, and cancer may decrease in the sense that if cancer gets you, it gets you sooner. But now we'll start seeing other concerns, including a stroke or dementia, that may start increasing as factors for death. And in this case, you could see how Alzheimer's disease increases from 5.8 to 9.2 percent of the impact on death. And certainly they are all connected with aging, with obesity and diabetes. So this is taken from the American Diabetes Association guidelines, how we approach now a person who has these conditions. And I will expand more about the targets in a minute, but I wanted to at least recognize that we're trying to propose a framework where as people get older, they're getting their treatments according to their needs. So if a person is older, that's not the end. It might be that you could have a person with diabetes, with obesity, but if they're still having normal function or at least few chronic conditions and they're independent, we may need to be as aggressive as if this person was 45 years old. As aggressive to prevent complications if they may live long enough to develop them. So in that case, that's the view of being more intense for the people who really need it. And I cannot underscore enough the importance for everything you see on the left as tools and resources that we could use. And whenever we're going to talk today about metabolic control or diabetes control. I may repeat it several times. Lifestyle is a priority because it's the one that may have the greatest potential, as it is one of the ones that have the more complexity in terms of variability. Plenty of studies, not a perfect one. We will need to have something that is true long, but that could support any of the metabolic risk factors we discussed before, the ones that could affect the most are nutrition and exercise. In this study, they compare the risk of development of dementia. So I think it's more of the same. Let me just move to this case. If we have a 73-year-old who presents for follow-up for diabetes and bone health, this person had to have a T7 compression fracture, was admitted with severe hypoglycemia, and he was on insulin, different types, the long-acting and the short-acting. This is a real case. I'm more or less giving the picture of the case without diving into details. But what I want to get your attention is I'm not addressing yet memory. This person, 73, is older, has not only diabetes, but now osteoporosis given the compression fracture, and is presented with hypoglycemia, low sugars. The person is on multiple doses of insulin. So the concerns are related to not only the impact of the glucose control, but the outcomes of how we can approach results that may improve his life. The patient is using, and you may be aware, I mean, it's not widely available in the world, but he was using a monitor. It's called Freestyle Libre 2. But even no monitor, even a good one, is great if you don't bring it to the office. So he didn't bring it that day to the office, and he was reporting his glucose was mostly in the 90s. So a message for your patients, if they are reliable, believe them. And if they tell you a number that makes more or less sense, at least the way to I was trained how to figure out when you're dealing with an older person with diabetes. If they tell you numbers that they always finish in zero, that might not be true. But if they tell you numbers that may fluctuate, that may seem more real. So I'm sorry for the font, but the A1C is well controlled. A1C is here. This is in percentage. I'm sorry, I don't know if in Sri Lanka they use a different mean, but I'm happy to take questions later on. But this will be considered on target. And his metabolic parameters are fairly okay, with the exception of the renal function, as you see there, and poor renal function in an older person with diabetes on insulin means an increased risk for hypoglycemia. Not only because, as is suspected, that there might not be an excretion of the insulin as intense as in younger people with normal function, but also I want everybody to remember that the kidneys are an organ important for gluconeogenesis. So as people start having chronic kidney disease, stage 4, they may start having problems with their own counter regulation for when the glucose drops, and that may increase the risk for low sugars. And as you can imagine, if this patient had what? Dementia, we will need to start worrying more about how we can approach the care in a safe manner while achieving the targets we need without risking more complications. Briefly, this bone density test confirming the osteoporosis, which already we knew because he had a vertebral compression fracture. I don't mean to go through all these other than highlighting this is complex. Once we start dealing with a patient with this age level, with not just one, but several chronic diseases, on a complex regimen, who may already be experiencing a high risk for complications from said treatment, even though it's needed, like the low sugars. And we need to address now that it's not only about those organs, but also the kidneys are starting to have problems. And then it's going to require a lot of thought and a lot of changes and a lot of interventions, from the pharmacologic changes to the what may be the best targets to how would be the best approach to monitor this person. And what if now we need to worry about if this patient is having memory problems? What if the low sugars were not because the doses were incorrect? What if this person is having dementia? I'm not saying he has, but I'm saying just think about it. And if the person has any type of forgetfulness, what if he forgot to inject, that he injected the insulin and then injects double dose? And what if, as they forget to eat or may feel like not eating, they have the correct dose of the treatment that was working before, but now they're eating less? And if I could continue with the what ifs, what if now with maybe some cognitive changes, they feel less interactive or they feel some degree of adjustment disorder and depression, and they may not feel like going out and walking and doing more things that they used to do in a group. Hence, their insulin resistance increases, or in other words, their sensitivity is not as great as before related to the activities or exercise they were doing, because now they're moving less, because they're feeling more ashamed. That sometimes happens when people start having memory problems. We could continue this route. And what I'm trying to get at with this is that we need to assess cognitive function. Is in the guidelines, is in the recommendation for older people with diabetes. There are multiple ways to do it. This is a slide taken from the review syllabus, from our geriatric review syllabus, just as to present the different means that we have to assess for cognition. There's a test called Mini-Cog. You could see in the time there, it will not be time consuming. It's only 3 minutes, even though I know, because I've done that before, when you have to see 20 patients in a day, 3 minutes count. But it has a good sensitivity and specificity enough to say that 3 questions may help us to address uh, cognitive function. As you go down the list of potential testing, most people, I hope, have heard before about the Montreal Cognitive Assessment, or MOCA, or the false mini mental examination status, or MMSE. Those tests certainly take longer. I have the luxury in my clinic where we have trained the medical assistants for them to do the testing before they come into the geriatrician office. But I can share that even though this is true in the geriatrics clinic for older people with diabetes or without diabetes, in academic centers like here, the same doesn't happen when we deal with my other days of clinics under my endocrinology hat, and I'm seeing other persons for their diabetes, but I don't have this luxury. I do not have medical assistants who will do the cognitive assessment for me. That was in the end the foundation for the study I'm working with IBM. Um, The Minicog, again, if you Google it, I'm not sure if you may start to build up some dissemination of basic testing for cognitive tests. It involves components for word registration, the ability or dexterity to draw a clock, and then the short-term memory to repeat a few words. So those involve not all, but some of the components of high mental processing that we need. Um, there are different ways to accomplish this, even though the Canadians have done even their tool through through an iPad. You could see that the difference at the bottom, how the clocks may look okay on the left-hand side. On the green, they're asked to draw what would be 10 past 11. But if you could see on the right-hand side, people may draw correctly the circle and the hours, but they don't put the time, or people may draw incorrectly the hours and may put them in the wrong place, or people may try to put the time, but it's definitely not great. And I have seen, and this is of course just an example, but it's sad to see how when we give for granted, if I ask anybody right now for you to draw a clock and put the hour, you probably don't even think twice. You may actually feel bad that the circle doesn't look perfect, or that the numbers are not symmetrical where you would like them to be, but recognize that as we get older and as function declines, it's not an issue of dexterity. These people may not have Parkinson. It's not an issue that they had a stroke and they cannot write it correctly. It's an issue of mental function impeding the ability to execute a task. Now, I just want you to make the connection. What if this is about just drawing a clock? What if this is about taking insulin correctly? You can tell now how that the connection starts to build up and becomes more clear. So addressing diabetes targets, I think I have a better slide where we can see the numbers, but we want to make a correlation between what are the glucose levels and the A1C. Generally speaking, an A1C of 6.5 is approximately an average glucose of 140 with some fluctuation, but it doesn't mean that the people are on a flight and all day long. And the A1C, you could have the same A1C of 7, and you have people who will be consistently in range, as you could see on the right side of that figure. There could be also people who are mostly in range, like 70% in range, but they do have fluctuation, especially the peaks after eating. And it's possible, as we could see now with these technologies, that people may eat, and we are used to asking about the glucose before meal, and then people may check again, as you probably do in your clinics, to check for the glucose before the next meal. What these continuous glucose monitors are showing us now for about 10 years or more, it's been more, but it's showing us numbers that are in between. And therefore, in between, we know, and we have data, and we have work on people being wing target before the meal, but there's a big difference between how high that glucose can peak related to the meal, the carbohydrate load, the glycemic index of the different foods. But for the sake of this, I will talk more about later, but for the sake of this explanation, it could still be the same A1C, but the peaks may still come up and then come down fast enough to give us the same average. But this person is already having some more risk for complications. And in the left-hand side, the person who is 40% in range not only has peaks, but also has valleys. And those are the valleys that are more troublesome because there could be hypoglycemic events that we want to avoid. This is from a real patient. I know that technology is not available everywhere, but I just wanted to highlight how complex it goes when I assess care, because it's not about just having the average of A1C, but recognizing that some patients may drop even to the 50s. And if we don't address them, it will come into trouble later on. And you could see also how, even though this person, I'm highlighting in the circles, the low sugars, on the right-hand side, you see how the glucose is going even up to 350. So this is a significant wide variability that we need to fix. And in order to treat this person, the first step is to detect why they're having lows and prevent the lows. The glucose may remain in 300, so we need to raise up the whole section of glucose levels until we accomplish better results. This is a complete different scenario where the average glucose is 135 in average, but you see how the person is having peaks above 250. So certainly there's another role for working in this person. And we need to understand that this might not be every day. That's where the variability plays a role. And if you see those blue bars, the vertical ones are describing how at the same time of the day, around 10 p.m., this person is having some days the glucose in normal range in 150s, but sometimes it goes above 250. Okay, this is another way to see the report where we can see how the traces here are representing different days. And as you could see, some days the glucose may go above 250, other days it may drop below 70. I will wish that there will come a time when this will become more available everywhere, but I need to highlight how, if we don't have more of an in-depth assessment for people, especially if they have the risk for complications or worse outcomes from hypoglycemia, like the older person who may have memory problems, who may have more risk like chronic kidney disease, who may have some degree of impaired mobility, you need one low to have one fracture or one traumatic brain injury or one death or worse disability. So let me now, I think I made a point clear about this. For the sake of time, let me jump to the different targets. So this is what I mentioned. It was smaller in the figure before, but now I can bring it up bigger. And this is from the American Diabetes Association guidelines for assessing the targets. It's a framework that exists for more than almost 15 years. It was from the consensus from the American Geriatric Society and the American Diabetes Association. It was published in 2011 or 12. And I know it because my mentor, I was lucky enough that I had a great mentor, and my mentor was one of the authors for this framework. The framework that made it to the guidelines. And what you could see here is that as we are addressing a healthy person, the healthy person may need a reasonable A1C, could be less than 7, with reasonable targets. And these numbers change through the years. I have to let you know right now that I see this slide, and I know the slide has changed because the guidelines are updated every year. But I want you to pay attention to the center, in the sense that now it's no longer a healthy individual, even though they're older, but they're already having problems, including mild to moderate cognitive impairment. So for those patients, we want to be less intense or aggressive because the treatments themselves may end up giving more problem. rather than the benefits that the person could have for. And of course, in the end, in the red on the red square, for the people who may have, unfortunately, more advanced issues, some type of terminal cancer or severe dementia, for these folks, we're not aiming for preventing complications, the long-term complications. So we're not going to try to have a strict glucose control because they're not going to benefit from it. They could have just more complications. I'm just going to emphasize something now. However, very clearly, it does not mean we let the glucose go to 300 because that will create now urgent complications, the ones in the very short term. Hyperglycemia from high glucose, there's something called the renal threshold. There could be some back and forth discussions about what's the level above which the kidneys will no longer reabsorb glucose. So then if you have a glucose of, if we describe more than 220 milligrams per deciliter, if there are different levels, we have to talk about it, but you see the millimoles per liter. But if it is more than 220, the person could have glycosuria, meaning the elimination of more glucose in the urine. That glycosuria can lead to polyuria, meaning the person may be urinating more frequently. Again, this is an older person with some memory problems and maybe impaired mobility and other risk factors. Fracture risk potentially. Now he's rushing to the bathroom, not because we are not or decided to avoid diabetes prevention of complications in the long term. But again, we still need to control that glucose because otherwise hyperglycemia can lead to this polyuria that can lead to urinary frequency, that can lead to maybe some type of urinary incontinence, and then they're running to the bathroom, they might be falling, or they might be just having so much urine out that can create volume depletion and from their hypernatremia leading to delirium. So those are all the things that we want to prevent. That means still there's a room for treatment control in the older population, even if they have some type of dementia. So I'm gonna say that most of my patients say that they eat healthy, but they don't. And I need to start every day emphasizing the need for higher protein in their diets and some healthier approaches to their nutrition. Also, whenever I talk with them about intentional weight loss, my oldest patient for whom I'm doing some intentional weight loss is an 84-year-old lady now because she has no dementia and she has very good family support and she has a family history of longevity. If I let her have still the obesity without treatment, she may end up having diabetes or complications from those that she could live long enough. So then that's an extreme, of course, but as an example, we can still address weight management in an older person. Now, it doesn't mean that for an older person with dementia, we're going to foster weight loss, but it doesn't mean that we're going to just let them sit all day long without moving because that sedentarism will end up creating other problems, including complications. If we just think about the diabetes, the glucose may go up because of the insulin resistance associated with the sedentarism. But also, if they lose mobility because they don't move, they may end up having other mobility problems. Treatment simplification. This slide has been updated for this year, but I think the message is clear, and I'm gonna go. I think I have a better slide for this later on. But the purpose is to understand that if you have an older person with problems, we have to just address them, individualize them, and figure out what are the targets, so that maybe we need to and we could simplify the treatment while still accomplishing the outcomes that we want to do. I have a second case to discuss, but I think I want to have and give the audience time to share some questions and discuss. I just want to bring up a complexity of this case with a different type of diabetes on higher doses of insulin, on multiple medications. And I think it's usually in my clinic, not only diabetes, but also hypertension, dyslipidemia, heart disease, chronic kidney disease, and the diabetes is not well controlled, and they're 72 years old. So then I need to assess target, but I also need to understand this person may have geriatric syndromes, and I need to figure out, including the risk for dementia. So let me then skip this slide because I think we're going to repeat many of the things we discussed before. And while I will highlight that there's different aspects, and I could dissect this case for each step of the way for the items that are required to be changed. For instance, the combination of glimepiride, which is a sulfonylurea with insulin, is a high risk for diabetes. for hypoglycemia, sorry. And then we need to improve still that diabetes. It doesn't mean that if we stop the glimepiride, we're not moving the A1C lower. It's about understanding better why the glucose is jumping, and maybe it's nutritional factors, maybe it's lack of exercise, or a combination of the above. And we still need to prevent any of the complications that you could see on the right bottom side, from the cognitive problems to address if the person has depression or urinary problems or falls or frailty or pain. So let me skip these ones because I do want to address more. I want to address what to do about this. And I think something that might be at hand everywhere in the world. In 2017, I was lucky. Our team was invited to do a very good paper for the supplemental in the journal Diabetologia to celebrate the 60 years of metformin. In that paper, in that supplement, many authors across the world join efforts to highlight the history, trajectory, and studies where metformin offers significant benefits for patients with diabetes. And for the longest, before we did the cardiovascular outcome trials in the 10 years ago, before that time, all guidelines would say that the first line treatment for diabetes was metformin. It's still safely used. We have more than 60 years of use now. It's going to or 70, will go to 70. And the issue is that there was already some evidence that was grown through the years where metformin may prevent DNA damage and inflammation. Multiple studies have addressed the connection between better outcomes in people who take metformin, and it's been suspected that they may block inflammatory pathways. And if you remember a few slides ago, the different pathophysiologic pathways that which connect obesity, diabetes, and dementia, perhaps metformin could have a role to counter those and reduce the excess production of peroxide, meaning less free radicals, and also inhibiting mTOR signaling pathways, which is a good thing for you. So what's challenging is that there's not been the perfect trial design to address that metformin is good. These are all observational or tend to be retrospective, and whenever you do that, you're going to miss some parameters. So an ideal trial design, I think, will need to be randomized, prospective. We need to consider that it's not just one intervention, and you cannot just randomize people to metformin or placebo without accounting for lifestyle, for socioeconomic effects, and everything we've said before in a slide where we had multiple parameters that could have a role in the development of dementia. It will still need to be very large to be power enough to see the changes, and it will need to be long. And everything I say here, what it means, it will need to be really expensive, in the billions of dollars, to really have the ideal outcomes. So there will be still barriers how to understand that dementia may be connected to the ideal treatment plans. But I think if we still consider what are the foundation, the basics, the eating healthy, the having good lifestyle, then a careful selection of medications will help us understand the potential for benefit in this population. This is a slide I meant before to understand better the A1C targets. So in an older person, the A1C, depending if it's a healthy individual, should be less than 7. So that means that the average glucose could be 154. And if it is between 7 and 8, it doesn't mean that the glucose goes all the way to 300. And 8 is an average glucose of 183. And when I try my patients to keep them, is to keep them below 200. I say that because when they have a 210, I don't worry. I just say the renal threshold is 220. But a person with moderate dementia, with an A1C of 8, it means that their glucose should still be below 200 the vast majority of the time. And the current version of the Chapter 13 of the American Diabetes Association standard of practice is the one focused in older adults. It has changed and now has this very beautiful framework for an age-friendly, comprehensive view to the older population. And I'm just going to say here, enhances again the need to address the complex patients who may have mild to moderate cognitive problems, or the very complex who may have severe dementia, for whom the targets are very similar in terms of glucose, but we need to address in more depth what might be the other factors that could affect their health. So I'm proud to share that this is still reference 96, is still addressing something we wrote in a paper from Diabetes, Obesity, and Metabolism many years ago, and is still quoted by the guidelines for the past 10 years. This is the figure of the vision we had when we approached an older person with diabetes back then, and that figure I've used through the years to evolve to the one that I showed earlier. And if you read for the chapter recommendations, it's a lot of words, but it's simplified. Reduce risk of hypoglycemia, avoid overtreatment, de-intensify, decrease treatment burden, reduce cardiovascular risk when applicable, and reduce cost barriers. So I'm still with time for questions, but let me then finish here. As I mentioned before, I am a member of the ACE task force for guided on diabetes algorithm. So I wanted to clarify what we say in the ADA guidance about cardiovascular prevention. Your older person with diabetes and maybe some memory problem or dementia, let's say that he's 75. He was 74 and 70 and 65 before. So they come already with a history. And in that history, if you already have pre-existing diabetes with heart disease or some of what we call the complication-centric approach to diabetes, this person should be on hopefully the right type of medication available for them to be treated. So even if they have memory problems, but if they had heart disease, they should be, if possible, exposed to a GLP-1 receptor agonist or an SGLT2 inhibitor. If they had heart failure, an SGLT2 inhibitor. If they had a history of a stroke before, a GLP-1 receptor agonist or pioglitazone. We just co-authored an editorial in JAMA to address studies from before and new other studies that are supporting the evidence for pioglitazone, which may be available for you too. It's a cheap medication. I use it more and more now for the treatment of diabetes, but it may have some benefits. In selected populations, it might be actually a good choice. And if they have chronic kidney disease, which I repeated several times today, an SGLT2 inhibitor and GLP-1 receptor agonist. So that means that this population, people with older age, diabetes, and maybe dementia, they still would need to be assessed considering what other diseases they have to select the medications that apply for them the most. And if we go now to the glucose-centric approach, we have to just start by understanding what is the target. Again, what's the type of person that I'm dealing? Somebody who's healthy, complex, or very complex. And then what might be the glucose levels that I want to address. And significantly, I want to prevent low sugars as much as I can. So concluding, for people with dementia, there's also the challenges that are related to dementia itself. Dementia may be associated with changes in behavior. So they may be agitated and don't want to take the medication. They may have anxiety or depression. They may not go out to exercise. They may have poor sleep, and poor sleep impacts metabolism. So their diabetes control may be more difficult. They also may have changes in eating habits. And the eating habits might be that they eat and eat and eat because they forgot they ate. Or worse, they stop eating. And that's actually one of the signs for a more advanced disease. And that stop eating means an intentional weight loss. And with weight loss, guess what becomes easier to control? Or in other words, more risk for low sugar. That's diabetes. So we need to figure out all of these problems in the more advanced stages. They are unfortunate. They may have actually dysphagia, meaning they can still have a problem swallowing, and many people may actually keep the food in the mouth. That's called pocketing. So it's quite a wide array, and I could share with you the Alzheimer Association offers available online multiple resources that could be used to learn more about dementia and provide education for patients. So I think we have good time for now questions, and I really appreciate your assistance today, and I look forward to hearing your questions.
Thank you very much, Dr. Valencia, for that excellent presentation. I think this is a topic which I think it's very difficult to tackle within 1 hour because it's so complicated. But I think it's very relevant to Sri Lankan population with the high prevalence of diabetes that we see. Because as you correctly mentioned, cognitive testing is time consuming, but at least the audience today, if they had taken the message home, the importance of at least doing a mini cog and, incorporating the holistic view when you're managing a patient with diabetes. And although we don't have the luxury of continuous glucose monitoring, I'm sure in the future we will be able to use these technologies when managing our patients. So the case-based discussions were fantastic because we had the a full insight into how managing, complicated diabetes in this older age group, um, how to navigate through that. Are there any questions from the audience? You can type it in the chat box or directly unmute and ask as well. I know there are, postgraduate trainees and medical students. If you want to know anything about the continuous glucose monitoring that Dr. Valencia mentioned, or anything else regarding diabetes and dementia. Any questions from the audience? I think I'll have to tell Dr. Valencia that usually our audiences are very quiet, unlike Western audience. So if you don't want to raise your voice, you can always type it in, any questions that you may have. Yes, thank you. Harindo has mentioned that thank you for the presentation. Can we use continuous glucose monitoring in dementia patients? I'm worried that they might pull out an unfamiliar structure. Yeah, and what about showering? So it's a very relevant question, Harindo. Dr. Valencia, how do you feel about dementia patients wearing continuous glucose monitoring devices?
Well, the companies have been moving away from the older systems that would allow to have a reader that will be smaller than this, and the reader will normally go into the arm, and then we could see the levels in the reader. That was the Freestyle Libre 2 from a company, and it's having a now the Freestyle Libre 3 that still can have a reader. But where I'm going is that the majority of these continuous glucose monitors are usually installed with an app that has to read through connected with Bluetooth Wi-Fi to have the information sent to the phone. So the challenge I see the most in many older people with dementia is that they don't have a phone. It's not about the device placement. All people could shower on it, and now they can last up to 2 weeks. Is usually with this type of population, they are maybe less active compared to some younger, still older adults, if that makes sense, who are maybe bumping on doorways. I mean, actually now there's now a different type of continuous glucose monitor that can be implanted subcutaneously and provide information, but still the limitation is that most people, older people with dementia, do not have a phone. I have a couple of patients for whom I discussed, and the family got them a smartphone, not because the person is going to be skilled enough to use the smartphone for apps and stuff, but it's because they could just have the smartphone at somewhat relative distance, so then the information for the continuous glucose monitor can go to the smartphone. And remember, the advantage here is quality of life from not having to test. Now, you do not need to have a continuous glucose monitor. You don't need to worry too much about glucose trends if somebody is type 2 diabetes, older, only on metformin, or maybe with monotherapy with a GLP-1 receptor agonist or an SGLT2 inhibitor. You don't really have to have a continuous glucose monitor permanently. I actually would argue, if we go now to the extreme, somebody who is on insulin, that's really required in order to accomplish better care. And as time will move forward, I hope it becomes more available where you live. I think I see an advantage from continuous glucose monitoring people with dementia because at least we could have an idea where the glucose is without poking them. And in terms of the level of control, once we have an idea that certain eating patterns are consistent, we tend to have a period of time where we donate the monitors to our patients as these companies bring those to us. And if they don't have access to them, at least we try to maximize the information during a 2 week window of time where we tell the family to write on everything they eat and everything that happens and time the medication. So we can now understand the trajectories of the glucose and match them with their behaviors. So in that sense, I see more benefit. Again, the showering is not a problem. And if anything, it could be an advantage for quality of life since it is not the same Remember, the glucose monitors measure glucose in the interstitial fluid, whereas when we do finger sticks, that measures in blood, some in the blood level. So the blood level is more time, real time. The interstitial is 15-minute lag, but still quite helpful. And in the end, the information might give us a better insight, especially to prevent the people who have significant fluctuations.
Thank you very much, Dr. Valencia, for that excellent explanation, because it's a novel topic for our audience about the use of continuous glucose monitoring. And I'm sure in the future, our students, when they come out and practice by that time, I hope we'll have that luxury. And in the absence of any questions, I would like to conclude this webinar by thanking Dr. Willie Valence, all the friends from USA, and looking forward to future collaborations. And thank you very much for spending your valuable time with us. And I think you have a busy clinic schedule ahead, so we'll let you go. Thank you so much for joining, and I thank the audience for joining and participating in this webinar, and we look forward to future collaborations. Thank you so much.
Thank you very much. My day just starts. I have to see now many patients. Thank you very much. You have a good day.
Thank you. You too.